let me introduce Dr. Malcolm Finlay, who's a reader at Queen Mary University of London and consultant cardiologist and electrophysiologist at Barts Heart Center. Malcolm is also a co-founder at Epicardio. Malcolm, you're the host, so you can share your screen now and the slides, and then I'll follow up.
Super. Thank you, Vasily. Thank you. Thank you very much indeed for joining us today. So let me share the screen. Make sure this works, and maybe everyone can see that. Can you just confirm that you can can see this? Yeah. So I'm a consultant cardiologist at Barts Heart Center. That's Barts behind me. We're one of the biggest electrophysiology centers in the UK and in Europe. So I have some classic. So I've just got a message here saying that the Zoom link. I've just got a message from some people trying to join, saying that they need the Zoom link, Vasily. So if you don't mind just pinging an email, I think people are sending you emails there. So Epicardio was founded really on this idea that actually we have an understanding of the human heart and an understanding of electrophysiology, which is not the way I was taught in medical school. It's not the way that one generally understands it, which is that actually it's not the ECG, it's what's going on inside the electrical activity in the heart that matters. And straight away, this is, in today's talk, we'll go through really about how I use this and how my thoughts about managing atrial fibrillation can be framed by this simulation. So this is the basic interface that we'll come back to a few times of the epicardial simulation. This is a heart in sinus rhythm. You can see the wavefronts of activation spread through the atria and down the conduction tree to the ventricle, and that in real time is generating the ECG that we see above. We all know here what atrial fibrillation is in one level, right? So we recognize it on the ECG. It's a disorganized rhythm. Those of us who are dealing with it on a clinical basis see the left atrial, see that the left atrium is where most of the action is happening. It's distinct from atrial flutter, and the hallmarks on the ECG are that you have this irregular QRS complex and no P waves. And that's really where I got to when I was starting to train in the invasive and complex management of atrial fibrillation. But one thing that really struck me was this isn't what's happening in the atria. This is what's happening in the atria. So this is a simulation running of atrial fibrillation. The key thing here is that the extra ectopic beats from the pulmonary veins there we see at the back of the left atrium are sparking off sparking off ectopic beats, which then create these crazy reentrant rhythms. And we see, I'm just slowing this down a touch to make it more obvious, but we're then seeing these reentrant spirals and waves, and the activity within the atria is completely disorganized. We're seeing that as a hallmark of the irregular QRS activation, because then down the conduction tree, we are getting these essentially random activations of that to the AV node, and that produces that the AV node's refractory period changes, and that produces the irregular QRS complexes that we see going through. AF is a major problem. It's hugely common. Up to 1 in 3 of us will develop AF at some point of our life, and about 5% of us will need really medical treatment and treatment directed at atrial fibrillation. It's more common as one gets older, but that doesn't mean it's rare in younger people. In fact, there's quite a high prevalence in those of the age between 50 and 65. And so it's a huge cause of not just morbidity from the symptoms of atrial fibrillation, but also cause of mortality, with the risk of the most common cause of stroke is atrial fibrillation. And furthermore, you have the morbidity due to working age people being reduced in their capacity. So it has a huge economic impact as well. The underlying biology is complex, but essentially anything causing fibrosis in the heart can mean that actually these little sparks arising from the pulmonary veins can set up these reentrant patterns and cause atrial fibrillation. There's a couple of references there which really bring you up to speed with a current thinking about the biology behind in the atrium. How do we recognize this? Well, that irregular QRS complex and the lack of P waves, but on a practical term, I think the world has changed. So we're not doing 24-hour tapes anymore on our patients. People are coming to us, having spotted that their pulse is irregular on a Apple Watch or on one of their other home heart device monitors, and they're needing treatment and recognition. These devices are incredibly accurate, but your patients are now tech savvy and need and using what I've found anyways, using the Epicardio system to show my patients, that really brings another level of understanding into what the underlying problems really are, what the risks are from atrial fibrillation, the treatment pathways we can go down, and essentially by developing that understanding with a patient, I find it can really improve compliance and make sure that we're all on the same page. So this is the most feared problem of atrial fibrillation, and that is having a stroke. The major thing here is that left atrium is not pumping blood effectively. Now it's an atrial fibrillation, and that pooling of blood can form a clot. And this is kind of let's say, the more horrific part of a simulation where we see where a clot is transmitted up to the brain and can cause, once you've seen this, you've got atrial fibrillation, you will want to have anticoagulation. But the good news about anticoagulation is it's really safe now. In fact, the latest data implies that formal anticoagulation has about the same risks as just an aspirin a day. So the same bleeding risks with apixaban as aspirin, yet about the same effectiveness as anticoagulation with either heparin or warfarin at preventing strokes. Okay, so once you've prevented strokes, what next? Well, we don't want the person's heart to wear out, and AF is a sort of potent cause of heart failure. And by persuading people to have a drug that which may have side effects, that's quite a thing to talk to patients about. One thing that drugs have been a black box, and they were a black box to me as well during medical training. And one of the neat things about a simulation is you can adjust the parameters according to the basic science on the cell level, and then the simulation will play back, essentially will simulate what that drug's effect would be. And this is pretty potent in beginning to understand how Flecainide can, for example, regularize the heart rate in atrial fibrillation, and how these other drugs like diltiazem and digoxin can affect the AV node. So that's this is a neat thing that just drops out of these simulations, the fact that one can begin to understand the real effects rather than just the kind of vague thought that digoxin is something for atrial fibrillation, for example. And when we're talking about, just give us a second, should move on, and the slide should move on in just a moment. So until very recently, the thoughts were, well, once you've controlled the heart rate, it's only symptoms that matter. Turns out that's not really the case. It's a more complex story than that, because when we try to get people back into normal rhythm, so that's rhythm control, get people back into that sinus rhythm, people die less, they have less strokes, their heart function is preserved better, and overall they have a better quality of life. And we're seeing this in several trials, that ablation, so catheter ablation of atrial fibrillation, is giving better outcomes than any of the medications we've had up until now. These outcomes are not just for symptoms. These are also for actual life expectancy. So the Cabana trial, I think, showed that pretty conclusively for patients who underwent catheter ablation in all comers, and a group that is severely hit by atrial fibrillation are those people with heart failure. And although this was built on many years of good evidence, I think the CASTLE-AF study, which came out about 5 years ago, this really changed the game and really meant that catheter ablation was shown to be a hugely effective treatment for heart failure where there's underlying atrial fibrillation. So, what is ablation? Well, what is the cornerstone of catheter ablation is essentially cutting off those the electrical activity of the pulmonary veins. And here I'm showing a simulation of us performing that. So this was so a ring of scar tissue forms around the veins as the catheters move inside the heart, and typically by radio frequency, but other methods of doing this are available. And as you'll see, as that loop closes, the electrical activity within that ostium of the vein will disappear. There we go. And that gives venous isolation. So it's kind of a limited amount of ablation that needs to be performed for the effect that it has. And by doing that, we close off those drivers, and the triggers for atrial fibrillation to occur. And normally either we give medication like Flecainide at the end of doing the pulmonary vein isolation, or perform a cardioversion to get the person back into sinus rhythm. I'm not showing you the cardioversion here, just but that is something that, of course, when we're simulating things, it's pretty straightforward to run a cardioversion there. There are three major technologies, two in widespread use. That's cryoablation and radiofrequency ablation. Radiofrequency is really what we've just shown you there, where we move a catheter around the inside of the vessels, giving lesions around the vessel. Up and coming is this idea of pulse field ablation, which really gives a high voltage electric shock to the veins to stop them conducting electricity. And that's something which is in the very infancy of its use clinically, but looks very exciting over the next few years. Whenever we talk about successes and outcomes, we should also talk about risks. So the outcomes of catheter ablation, frankly, are pretty good, actually. Many people, now we can expect a 85%, even 90% success rate in some groups of patients. So by success, I mean the person not being bothered by atrial fibrillation at all, really, and getting back to their normal life. I think with the persistent atrial fibrillation, so that's atrial fibrillation where patients are in AF the whole time, those success rates, we're still not there yet. And that's because really there's further scar within the atrium. And it may be, and it's likely the case, that just catheter ablation around the veins isn't enough and some further ablation is needed. There are risks to the procedure, like any medical procedure, but the nice way of framing it is the risk is about 10 times lower than for a hip replacement, at least in the data from our center. So, there's a risk of bleeding around the heart, which is treated straight away with a pericardial needle. So even though that can be a real hassle, that usually just requires a couple of days in hospital. About 1 in 200 to 1 in 500 people have a major complication. So that's something that will affect them going forward or is life-threatening, including stroke, heart attack, or damage to the valves. And dying, patients have died after the procedure. So it's about 1 in 2,000, 1 in 3,000 patients. Nevertheless, like I say, when you look at a hip replacement, which people have as that elective hip operation being a super routine procedure, those rates are about 1 in 200. So it's a very safe procedure. So when we come to the AF ablation is not suitable for all patients, and many people are still bothered by their abnormal heart rhythms, but they're still bothered by a rapid heartbeat conducted down their AV node. And the use of a pacemaker can be really helpful for these people. Pacemakers are useful because, number one, you can increase the medication that the person's on. Often you're unable, you get this sort of bradycardia at night time when people are fast asleep. They'll have a slow heartbeat without a pacemaker in. If you give them further drugs to control their, if you give them more drugs to control their heart rate, then they can get symptomatic either at night or during the daytime from the heart going too slowly. And likewise, people have symptoms from side effects from the drugs itself. So what we're showing here is a person who's had their pacemaker implanted, and if they don't want, so that gives it backup for that slow heart rates. But the other way of doing things is by doing a catheter ablation of the AV node, and that's something that we've just shown here, where lesions are performed around the AV node, and now we're sort of dependent on that pace. We're dependent on the pacemaker, and the pacemaker's kicking in. That's what we're showing here is a full simulation. This is obviously a video of us using it earlier, but the ability to you can just drag and drop and put the lesions in wherever one would like, and if you put them in the right place, there we are. We've now delivered energy to the AV node, and we've got complete heart block, and the pacemaker is taking over. Okay, so that's really coming to an end here. So the key messages, I'd say, for management of atrial fibrillation are that one should anticoagulate the patients to prevent those horrible strokes. You should control the heart rate of your patients, and that can be really by medication as the first step, but there's a really low threshold going forward for ablation and rhythm control. I think these are really hard concepts to get embedded into one's unit and embedded into one's the staff one works with, and also in that process of going through the options and the ideas behind a treatment path with a patient. And so this is where I think the epicardial simulation solution comes into its own in education terms. It gives an opportunity for patients and colleagues and junior staff to really go through in detail and understand from the bottom up what it means to have atrial fibrillation and what the treatment strategies are directed at. So I'll pass on to Vasily, who I think you're going to go through some example of where epicardial simulation has been used to great success. Thank you. And we should say we'll take any questions, just post it up in the chat, and we're delighted to, or just raise your hand.
Thank you, Malcolm. Thank you very much. I'm going to reclaim the host and share my screen. If you stop sharing your screen, yeah, I think you have already. And okay, share screen. So before we go into question and answer session, and as Malcolm mentioned, let me just tell you a few words about Epicardio. Well, at Epicardio, we bridge the gap between theory and practice in an accessible and cost-effective way on your own device. We use validated and accurate simulation of cardiac electrophysiology, incorporating our cloud-based interactive real-time 3D heart simulation platform. As a case study, I will show you what we've done with Oxford University, the medical school there, the Department of Anatomy and Physiology. It's, bear in mind, is the best medical school in the world. And practically, they train on Epicardio at the year 1 and 2 when they do anatomy and physiology of the heart. Practically every graduating doctor from Oxford is trained with Epicardio. We have installations also at Cambridge and Karolinska, but I will speak to in one minute. In terms of corporate training, we customize the Epicardio platform for specific pacing devices, such as embedded pacemakers or external temporary pacemakers, and thus enabling cost-effective and accessible corporate training. We have a global user base, and we've been adopted by leading medical schools around the world, also leading cardiac device manufacturers. All Epicardio content is either available on App Store or Google Play, or on the Epicardio eShop via direct subscriptions. I will go into question and answer now. Sorry about this interlude. You can either type your questions on the chat or raise your hand. I think there is a facility to raise hand on the Zoom app. Thank you.
Vasily, one thing I'd like to ask you is just what do you think is the most challenging part of developing the simulation? You've done a fantastic job with it all.
Well, the most challenging is the accuracy, and really getting it independently validated by experts clinical experts and industry. And this has been it's taken a long time to get the signals accurate enough to be kind of taken as real cases. But we've gone through that hurdle. That was quite a challenge again.
Yeah, and maybe you just give us a brief peek into the next kind of exciting stuff around the corner that we can see from. Well,
we're moving more interactive, and particularly in terms of catheter ablation and cardiac EP, all procedures in cardiac EP, particularly navigating catheters and customizing for specific catheters or specific systems in EP mapping. And the biggest challenge for the future is to make patient-specific simulation. So that's one step ahead, is to be able to do preoperative planning for ablation and all that. Yeah.
Yeah. So I imagine that that's a sort of next big step for us. And what about things on the App Store? Is anything further coming up from the App Store?
Well, for the App Store, we will have more corporate apps for specific devices, and this will be like for the big names of big name device manufacturers for pacemaking. More specific device, but also our content. We have about 38 tutorials. We will be releasing practically everything on App Store as we go, step by step. But that's only small chunks of like we've done with AFib and temporary pacing. But we will be doing a series of more as we go. I think we have some questions. I think there's a question on the chat. Stephanie, is that the question? Understanding the substrate and disease development is so important. Oh, that's just a thank you, right? Sorry, that's just a comment. Yeah.
There's I would agree with that, actually, that it's very, very easy for people to when discussing, particularly with patients and also with other colleagues, to discuss about atrial fibrillation as if it's something which is a minor problem, a minor hassle. But frankly, having people recognize that there's an underlying substrate problem with the heart, that's a big deal that changes people's thinking about how to treat AF and how to then manage it going forward.
Yeah.
There's I mean, there's this thing we struggle with as well, that, and actually thanks to the Apple Watch, I think people are getting more and more understanding the symptoms related to their AF. And it's very hard when people just think they're getting old, when they're coming on and off with paroxysmal atrial fibrillation. People will say, "Oh, I don't feel so well today. I feel a bit tired." But then they get their Apple Watch for Christmas, and then they're realizing that actually, when they're feeling tired and washed out, they're having episodes of atrial fibrillation that wipe them out for the rest of the day. So the symptomatic and the kind of burden that people get from this disease is we're just really recognizing that right now. So I think the next 10 years are going to see a burgeoning in the demands for treatment and the types of, and also the wider number of people demanding that they have their AF treated properly.
Absolutely, yeah. The more wearable devices, the more consumer wearable devices, there will be, the more kind of early detection of AFib will be. But of course, it may cause a lot of trouble for the GPs here in the UK. But that's another problem.
I think we can. Yeah, I think lots of
my GP doesn't want to hear about Apple Watch. So they think it's a kind of it's a curse thing. It's like
yeah, well, there's a real opportunity there, I think, for there to be joined up, really more wide and joined up direct access. And certainly we're seeing that so much in the private in the private sector. Yeah. People are just bypassing the NHS GPs, coming straight to see a private cardiologist with their readings from an Apple Watch, and then demanding directly that they get the treatment that they're
actually. Yeah, this is the case in many other countries, not in the UK, but in many other countries in Europe. People go straight to a cardiologist, and even the health system pays for it. Without, they don't have to go to a general practitioner first. They just they know what, I mean, they have made the diagnosis through the internet or their Apple Watch themselves, and they go straight to the specialist. Even demanding the kind of treatment of their choice, but that's, of course, that's different health system.
Yeah, so these challenges to, I mean, Steph, you wrote in the chat there about the challenging to educate GPs and referring doctors to expand the thing. My opinion is that these tools and these systems like Epicardio and the education offering there can be something different from just another pamphlet or a website to point people to, because of its interactivity, and people can get a visceral understanding of what's happening in atrial fibrillation, with the risks of the disease, and also the treatment. And by doing that in a structured process where you have we have CPD points, right? So there are CPD points available for these things.
Yeah, and one of the future products that we're bringing up is more patient education apps. In patient education, and again, if we do the step of connecting our simulation to a wearable device, we will have a patient education stroke look at your own heart simulation app. So that's something that's coming up future. Yeah.
Well, I will recommend they get a free course of anticoagulants if they're going to use it.
I'm sure that GPs will hate us down the line, because they will provide the opportunity to everyone to diagnose themselves, but that's too dangerous. Yeah, I know.
Great. So Vasily, that's been terrific thank you so much for
thank you, Malcolm, and thank you for your time. And particularly, I would like the background, the Barts Heart Center at the back I can see you in the city. Yeah, I know you are there, but this is a very, very successful image at the back. Very good.
Great. So I think that's probably time to wrap up and say thank you to everyone who's attended. Thank you so much. It was really appreciated. Well done.
Yeah, and we'll be on the email.
Well done, Vasily, for organizing this, all your hard work with getting this going.
Yeah, do email us if you want any specific information, or if you want some slides to follow up. I saw a lot of relevant names on the although we had about 15 participants, and they're all very relevant in cardiology. So we can follow up with specific slides or information about the content. Thank you. Thank you all for joining.
Okay. Well, thank you so much, everyone, for joining. Okay, bye now.
Bye, Malcolm.